This 48-year-old engineer presented with shortness of breath. He had smoked early in his youth, but was a non-smoker when he was admitted to our hospital. Note that the radiographic findings are typical of diffuse pulmonary emphysema. The heart is small, and the central pulmonary vasculature appears radiographically. These 4 images are of a pulmonary arteriogram, and they reveal the asymmetric pulmonary blood flow and the classic signs of pulmonary emphysema. A close-up of the left lung shows the typical findings of emphysema. The compression of intrapulmonary arteries, the absence of pulmonary vessels, the distortion of the pulmonary vasculature in the medial aspect of the left base. They appear compressed. There is separation of arteries in the lower third of the left lung, and there were no filling defects that could be seen within the pulmonary arteries. A biopsy of the lung revealed evidence of emphysema, but note also obliteration of pulmonary arterioles. Examination of the lung using polarized light shows the birefringence of talc granules that were seen occluding the pulmonary vascular bed. This histological section shows that the talc emboli showed birefringence when the slide is viewed with polarized light. This engineer was a drug addict, and he went to a methadone clinic. In order to get the maximum effect of methadone, he dissolved the methadone powder in water and injected himself in a peripheral vein. Over a period of time, I'm sure that he developed multiple arteriolar occlusions in both lungs, and this may have contributed not only to emphysema but to the mild pulmonary hypertension from diffuse microemboli. So it is possible that in the absence of bronchial irritation, emphysema may develop in some patients due to embolic phenomena, and in this case it was a case of talc emboli that led to emphysema, but the basis was extensive embolization of the distal pulmonary arteriolar